in October 2024. So I really just want to share with you the new requirements and try to make it as digestible and also as non-sleep inducing as possible. So if you've come for a whole pile of medical physics today, you'll be disappointed. If you've come for practical hints and tips on what you need to do and what the new regulations require, then you are in the right place. So for those of you who haven't been on one of these webinars before, I'm Pat Langley. I'm a dentist, and my absolute passion, apart from IRMER, is compliance and helping and supporting dental practice teams to be compliant with all the regulations, which are increasingly complicated, and actually I find it hard enough to stay up to date with everything, so I know just how challenging this is for practices. So I work with the team at Dentistry Practice Services, where we support about 900 plus practices with all this stuff you have to do, and IRMER is no exception. So lovely to be here today talking about this, and these are the learning outcomes. Oh, and I also just wanted to say a huge thank you to the Greater Manchester Primary Care Provider Board for inviting me to do these webinars. You know, I think that you are very lucky in the Greater Manchester area that your provider board has the foresight and insight to provide these kind of sessions, which I think certainly from the feedback, people are getting quite a lot out of them. So the learning outcomes from today are looking at the difference between IRMER 2017 as amended and IRR17. And we're going to look through the increased responsibilities for employers under the amendments, and they are significant. So I do hope there are employers on this today. And if there aren't, then you will get a PDF of this after the session. Rose will send through a PDF for you and a copy of the slides as well. So I hope that will be helpful. So we're going to look at how to ensure all team members involved in dental radiography are appropriately entitled and what that actually means in practice. And then we're going to finish up with how to manage accidental or unintended exposures. So let's just translate that into what it means in practice. So essentially, what you have to do is that before an X-ray is taken, the team taking the X-ray must know why it is needed. The right person must justify and authorize it. The image that is taken must be good enough to answer the clinical question that the radiograph was there to answer. The findings must be recorded, so the findings from the radiograph must be recorded, and the practice must be able to demonstrate that your systems are safe. So that's really putting it in plainer English, what we're going to cover today. Radiation protection matters in dentistry a lot. And just to show how immensely old I am, when I was a child, I remember going into shoe shops and they took X-rays of your feet. And so you could see what size shoes you should have from the X-ray. Now, thankfully, those days are long past, and there is a much better understanding of the dangers of ionizing radiation. So we're going to split this session today into 5 parts. The first part is we'll look at the legal framework. Second part is we will look at who is responsible for what. Third part is that we will look at what must be recorded. That's not just clinical records, that's records within the practice. Part 4, we'll look at quality assurance, diagnostic reference levels and audit. And part 5, we'll look at adverse incidents and how to learn from those. So those are the things that we're going to cover in sections, and then there will be time at the end for questions and answers, do please pop your questions into the chat, and I will be really happy to answer them at the end. So we will finish by 2 o'clock, but if the questions run out before then we'll finish before then. So part 1 we're going to look at, which is the legal framework. So X-rays are ionizing radiation, and as we know, the risk with dental imaging is small, but it's not zero. So it's small compared to the ambient radiation that there is in the atmosphere, taking a transatlantic flight, living in Cornwall. That there are, I think that what we do in dentistry is very low, but it's not zero. When I said living in Cornwall, that's a reference to radon levels that are in some buildings and some areas in Devon and Cornwall. And it is a legal requirement to keep doses as low as reasonably practicable, and that is called ALARP, as low as reasonably practical. So what that means is that all exposures must be justified. So there must be a reason for taking the X-ray. Somebody must authorize the X-ray. We must make sure that it is optimized. And by that, we mean that the dose level is kept low, that repeats are avoided if possible, and that the radiograph is taken in as safe a way as possible. And it must be clinically evaluated. And the records you have in the practice should show why the X-ray was taken and what was found. So all X-rays, just taking X-rays because an amount of time has passed is not acceptable. And all X-rays must deliver clinical benefits. And the benefit comes from information that you will use to confirm a diagnosis, to create a diagnosis, or to plan treatment, so clinical information. So X-rays are there to help you with diagnosis and also with treatment planning. And the harm that X-rays can cause can be reduced by making sure that you select the correct X-rays to take that show you what you need to see. So no point in taking bite wings if actually what you want to see is the apex of a tooth. So correct selection, correct technique, and avoiding repeats. So X-rays are very, very useful adjuncts in what we do in clinical practice, but they must be justified, and there must be a reason for taking them, and there must be a benefit that comes from taking them. So there are two key legal frameworks involved in radiation protection. The first of these is IRMER, so that is the ionizing radiation brackets medical exposure regulations, and these focus on the protection of patients. They also focus on carers and comforters. So these are people who need to be in the room for when the X-ray is being taken. So it could be a parent, if it's a child, it could be a carer, if it's an adult at risk who needs somebody there, but just somebody else that needs to be in the room and has good reason to be in the room when the radiograph is being taken. IRMER is there to protect them too. Whereas IRR17 focuses mainly on protection of team members and members of the public. So IRR stands for Ionizing Radiation Regulations 2017. So which framework covers what? Well, IRMER, protection of the patient, focuses on justification. So why does the X-ray need to be taken? What is the justification for taking it? Optimizing it, clinical evaluation, and all the employer's procedures and entitlement, which we'll come on and talk about in quite a lot more detail shortly. And the procedures and entitlement are a really important part of what we have to do in practice for good governance. Whereas IRR17 focuses on occupational risks, so that is risks to the practice team, and it focuses on public exposure, so making sure that members of the public are not exposed to ionizing radiation. So things like making sure that you have appropriate lead lining, that's been put in place by seeking guidance from your radiation protection advisor, so you're protecting the public from accidental exposure to ionizing radiation. Also focuses on controlled areas, it focuses on local rules, on dose restriction, and then all the engineering controls that we have to comply with. So that is making sure that all radiographic equipment is maintained, serviced, and checked at the appropriate intervals. So there's a lot to it, but IRR17 is not focused on the patient, it's focused on the risks to the public and team members and keeping those as low as possible through these things here. So it's true to say then that IRMER and IRR cover different areas of safety. They don't cancel each other out, so you don't need one in some instances and not the other. They sit alongside each other, and you can only be sure that your radiographic procedures in the practice are safe if you take account of everything you need to do under IRMER and everything you need to do under IRR. So safe dental radiography depends on both IRMER and IRR to protect patients' team, your team, and the public. Now, IRMER 2017 was amended in 2024, and the correct terminology, and this is really important, the correct terminology is now IRMER 2017, as amended. Now, all your written procedures in the practice must show that terminology, and if yours don't, then your procedures will be out of date. So that is something that you can check when you go back to practice either this afternoon or tomorrow. So it's now referred to as IRMER 2017 as amended. The 2024 amendment came into force on the 1st of October 2024, so it's been there for a little while. And the main thing it did was to significantly strengthen employers' duties, which is why I hope there are some employers on this today. And they actually are really quite onerous now, and we'll cover them in a minute. So what changed in 2024? Well, there is a big shift in focus towards written procedures, and that is written procedures that are specific to your practice and the way you do things. So not generic procedures. Now, I know if any of you have been on any of my CQC and compliance lectures ever, you'll know I talk endlessly about how having generic policies is not, it's a waste of time, money, and if you print them out, then paper. Written procedures must be specific to your practice and how you do things. Much more focus on quality assurance, clinical audit, and then making sure that your procedures for accidental or unintended exposures are strengthened. And that is particularly, doesn't just mean, where you've got a radiographic accident of some kind. That means, say you're referring a patient for an X-ray, and actually you've already got maybe to, maybe for a CBCT, maybe for an OPG, and actually then you discover you've got all the information you need. So, and really the X-ray probably wasn't justifiable in the first place. So that is an unintended exposure. So procedures around unintended exposures and accidental exposures are significantly strengthened. The written procedures must identify duty holders. Now I'm going to come on and talk in a lot more detail about duty holders and what they are in just a moment. So I won't go any further on that at the moment. And procedures must be clear about who in the practice is entitled to do what from a radiology, radiation protection point of view. So you need to have very clear records on that. And training records must reflect the entitlement. All of this will become a lot clearer in just a moment. So we're going to look now at just that thing. So who is responsible for what in radiation protection? So these are, I just mentioned just now, duty holders, and these are the key duty holders in dentistry. So you've got the employer, you've got the referrer, you've got the IRMER practitioner, you've got the operator, you've got the RPA, who is the radiation protection advisor, and they advise on all matters relating to IRR17. And you've got the medical physics expert who advises on matters related to IRMER. So those are the duty holders. So when I refer to duty holders, this is one or all of those people. Now, I said I would explain the employer responsibilities across IRMER and IRR17. So employer responsibilities are not just limited to IRMER, they're not just limited to IRR17, they go across both sets of regulations. And the employer has legal responsibility for making sure that all patient X-rays are justified, optimized, and safe. Employer is responsible for establishing written procedures and protocols, and I'm going to mention several times during the presentation that these must be current and accurate, and the employer has to formally appoint and entitle duty holders. So that's the list we looked at just now. So that's this list here. The employer is responsible for entitling all of those people in the practice. The employer must ensure that all clinical audits are carried out when they should be, and that audit results are followed up with action being taken if required. They need to ensure that radiographic equipment is tested and maintained. Now, some of these tasks obviously can be delegated. So it could be certainly ensuring that radiographic equipment is tested and maintained at the correct intervals could be delegated to the radiation protection lead in the practice. I'm a big fan of having different leads in the practice. So having an infection control lead, having a safeguarding lead, having somebody responsible for complaints handling and management, and somebody responsible for radiographic matters, or at least making sure that things happen when they should be happening. Employer is also responsible for appointing the medical physics expert and the radiation protection advisor, and also for registering with the health and safety executive. This became a requirement a few years ago. You must register that with the HSE that your practice undertakes radiography. I did say there's a lot for the employers to do. So all practitioners and operators, employer must ensure that they have appropriate documented training, must ensure all training records are kept up to date, and must ensure that referral protocols are in place. Now, as I mentioned just now, that doesn't mean the employer has to do all of this stuff, but it does have to be delegated. It can be delegated, but the employer has final responsibility for this. The employer must make sure that local rules are in place for each machine. They must appoint a radiation protection supervisor. And if it's somebody in the practice who is part-time, then a deputy, somebody so that you can always have a radiation protection supervisor in the practice. This is different from the radiation protection advisor. That's an external appointment. The radiation protection supervisor is an internal appointment in the practice. The employer is responsible for making sure that any accidental or unintended exposure is investigated and reported on. That's the final section of what we're going to look at today. So we've covered that already. Big onerous responsibilities on employers, and the 2024 amendment really has changed quite a lot of what employers need to do. Employers need to have entitlement records. Now, my recommendation here is that you have some kind of spreadsheet or log that shows the following details. So entitlement records should show who is entitled to do what in the practice when it comes to radiology and radiography. So the entitlement records should name the individual, define their role, be supported by evidence of training and competence for the role, and be very specific and show who can do what. So then let's look now at the other duty holders under IRMER. So we've got the referrer. Now this is in dental practice, this is a registered dental professional who is entitled to take radiographs by virtue of their training, who is then formally entitled by the employer to refer for an exposure, for an X-ray. And the referrer, so let's say this is a dentist who's wanting to refer out of the practice to somebody else. The referrer's responsibility is that they must supply sufficient clinical information to support the justification. So let's say you want to refer for a CBCT. It is the referrer's responsibility to make sure that you send with the referral enough clinical information to support the justification. So why the X-ray needs to be taken. You can't, the referrer can't just say, please take a CBCT, because the person at the other end will not consider that that is sufficient information to justify the exposure. So that's a really important detail. So make sure that you are clear on that. So then we come to the operator, and the operator carries out practical tasks. Actually, I think we might have missed out. Yeah, we've missed out the practitioner somehow. Okay, so the practitioner is a registered entitled dental professional. So again, this is somebody who is entitled by virtue of their training and entitled by virtue of the fact that the employer has formally entitled them. So this is, again, a registered dental professional who takes responsibility for justifying the exposure and authorizes it. And then we come on to the operator, and the operator has a long list of practical tasks within their entitlement. Now, this isn't going to all be the same person necessarily, or it could be. So these are the tasks that an operator could be undertaking. So that is identifying the patient, making sure that you know what the exposure is that you're going to be performing, and make sure that you take the correct X-ray. Positioning the X-ray tube and exposing, so taking the X-ray in other words. If it's a film, processing or managing digital images if you've got a digital system. Operators can also be responsible for quality assurance checks and recording, and also be responsible for clinical evaluation. Now, each of these roles carries its own duties, its own entitlement, and its own documentation requirements. Now, I've made it sound a bit complicated. It really isn't, because one person can hold more than one of these roles, or all of the roles, if they have the appropriate training and entitlement. So let's just go back now and look at the tasks. So patient identification and preparation, that could quite easily be done by a trained dental nurse. Positioning exposure could also be done by a dental nurse, provided they have the certificate in dental radiography and they are formally entitled by the employer to take the X-ray, or equally, both of those things could be done by the dentist taking the X-ray or the dental professional taking the X-ray. Processing or managing digital images, that again is likely not to be done by the dental professional, the dentist or the person taking the X-ray. It will be somebody who is appropriately trained and entitled to do it. Quality assurance checks and recording, again, that can be done. Doesn't have to be the dentist doing that, or it could equally be. So all of those roles can be held by a dentist, or some of them could be performed by a dentist, and some of the other roles can be performed by somebody else. So it's kind of a team effort, and it really depends what your practice setup is as to the most appropriate way forwards with that. So that is duty holders there from the perspective of what happens in the practice. Then we've got the other duty holders, which are the radiation protection advisor and the medical physics expert. So RPA advises on IRR17, so that's protection of the public and team. MPE advises on IRMER matters, so things like patient dose, optimization, quality assurance, and also it would be the MPE that you would turn to, the medical physics expert that you would turn to if there was an incident in the practice. And your records should show that appropriate support was sought where it was relevant. So, for example, in you're setting up a new surgery, then you would want to involve the radiation protection advisor in making sure that your controlled area and your lead lining and so on is all completely appropriate. So I think it is about really just involving the right person at the right time. Training and competence, the 2024 update talks quite a lot about training and training records. So training records should be current. They should show what training was undertaken and the date, and also, of course, relevant ongoing CPD should be evident where that's required. So with that, I'm referring to either a dental nurse who holds, or other dental professional who holds the certificate in dental radiography. I'm also referring to the GDC requirement that all registered dental professionals, dentists, must have 5 hours of IRMER training every 5 years. So really must make sure that all your records are up to date with all of those requirements. And bear in mind also that if you bring new equipment into the practice, so you bring a panaural X-ray equipment in, or you bring CBCT equipment in, then additional training will be needed for new equipment or new techniques. And bear in mind also that training should be particularly role specific. So the training that a dental nurse will need who has got a certificate in dental radiography is not as extensive as the training that a dentist requires. And the training and the role must align with what actually happens in the practice. So there's been, over the years, there's been a huge amount of discussion about who presses the button. Well, it's perfectly acceptable for a trained, a dental nurse who has documented training. Doesn't have to be formal training outside the practice. It can be formal training inside the practice, that they press the button to initiate the radiographic exposure. So the point here really is that the important thing is that the training should be role specific, and it should align with what actually happens in the practice. So we've talked quite a little bit now about entitlement and how that how important that is, and we've talked about what it should look like. Now I just really want to finish this section by looking at what it shouldn't look like. So weak entitlement, and bearing in mind that the 2024 update really focuses quite a lot on the importance of entitlement and making sure that only people who are entitled to do things do actually do them. So what does weak entitlement look like? Well, the roles are unclear, or there's no defined scope of practice. This is why I'm really keen on having a spreadsheet or just a table of some kind that lists the name of each person involved in radiation, in radiography, in the practice, and it defines their role and it defines what they're allowed to do. Weak entitlement would also be out of date or incomplete training records for the role for which the person is entitled. So training and entitlement go hand in hand. Or vague entitlement for more complex things like CBCT, or copied generic documentation with no local detail, or responsibilities that don't match what actually happens in practice. So I think this is quite an important takeaway from today. Just make sure that your entitlement records and procedures are what they should be. So now we're just going to move on to part 3 and what must be recorded. So a lot of this section now is to do with justification, and this is probably the most important part of this session today, making sure that each radiograph is justified. So every exposure that's taken must have a clinical benefit, and that benefit must outweigh the radiation risk. So we talked earlier about how the risk in dental practice of dental x-rays is low, but it's not zero. So there should not be a time where you take an x-ray and you don't have a good reason for taking it. And that good reason is the justification, and that justification must be individual to that patient at that time and that clinical situation. And that justification must be written. So you must have in the records the reason you are taking the x-ray. And you can only call justification valid if the x-ray is going to help you with diagnosis, so it's going to confirm something you suspect, or it's going to provide the diagnosis because you're not sure what it is, or it helps you with treatment planning. If it doesn't do one of those two things, then it isn't justified. And this is a really important thing because I still see this quite a lot when I do patient record audits. Routine radiographs. So for many years, it was a case of, well, we take bite wings every 2 years. and it's kind of, you take routine radiographs, you take bite wings every 2 years, whether you need to or not. Well, that is, that for some time that has been not, that's been unacceptable, but it's really important that that practice stops. So if you have a, in your practice, if it's your practice policy to take routine radiographs every 2 years, then you need to stop that and think about when the right time to take radiographs is. So I'll come on and talk about that in a moment. That's the selection criteria. So routine radiographs based only on the time interval are not acceptable or defensible, and it must be specific to the patient. And blanket screening without clinical assessment is not defensible. Now that happens in some parts of the world, so patients will have will attend an appointment and they'll automatically have an OPG taken. That is not acceptable in the UK. Must be a reason for it. And all X-rays must have, before you prescribe it, before you take it, you must have preceded that with a proper clinical examination, and that should lead to your decision to take an X-ray. Your records, your patient records, should explain why this patient needs this image now. And so how do you decide when to take an X-ray? So selection criteria are really important, and selection criteria will support consistent, defensible clinical decision making. Now, I'm kind of leaning towards taking too many X-rays here as being not defensible, but actually taking too few X-rays is also not defensible. So that's why the selection criteria are so important. And we'll come on to, on the next slide, about where you get the selection criteria from. And using consistent defensible selection criteria will help avoid unnecessary exposures. It will also help avoid you not taking enough X-rays, which also is not defensible. And clinical notes and referrals should reflect the use of selection criteria. Now, in the UK, the selection criteria is the standard reference that you should be using is the College of General Dentistry, CG Dent, previously FGDP UK, guidance entitled Selection Criteria for Dental Radiography. Now that is free on the CG Dent website under their standards guidance. There's a lot of standards guidance on there that is free to everyone. So please familiarize yourself with that. And that is a really, it's very, very clear about when you should take X-rays and when you shouldn't. So it's clear about what happens if you have a child with a high caries rate, what happens if you have an adult with no caries at all. It's all there in selection criteria for dental radiography. So please do use that as your guidance. If you decide to do something other than the guidance, than what it says in the guidance, i.e. decide that you're going to take X-rays every 6 months or every 3 years or 5 years or not at all, then that isn't, and it's not part of what it says in selection criteria for dental radiography, then and you have a good reason for it, then that reason should be clear and it should be in the records. So authorization we'll talk about now. So the practice should define how authorization is recorded. So that is the person who makes the final decision to take the X-ray. That is usually the IRMER practitioner. So the clinical record should show who justified and authorized the exposure. Doesn't mean you have to write an essay, but it should just be clear who has justified it and who has authorized it. And that record should be understandable to another clinician. So let's say somebody else comes in, you're off on holiday, or you're off sick, or off doing CPD, or for whatever reason, then, and another clinician sees your patient, then the record should be understandable in terms of why the X-ray was taken and the benefit it delivered to another clinician. Should also be obvious to an auditor or somebody assessing your records, or to the regulator. Now that could be to the GDC, or it could be to the CQC. So we'll come on now and talk about clinical evaluation. So we've talked about justifying the X-ray and justification and how important that is, and that must be written in the records. That's a legal requirement, by the way. And now clinical evaluation. So that means that when you take the X-ray, you must look at it and see what's on it, and then record what you see on it. And so every image must be clinically evaluated, otherwise there is no point in having taken it. So, and you must record your findings. And just writing down 2 bite wings is not enough. So you must report what you see on the X-ray. Again, it doesn't have to be an essay, but it does have to say what you see on the X-ray. So it could say, for example, instead of bite wings, it could say bite wings taken, but then you follow it up with no caries evident, bone levels as charted, no pathology seen. That's the kind of level of detail, not an essay, but it does need to say what you've seen. And also by recording what you've seen, then it proves you have evaluated it. Now, I'm a massive non-fan, as in I don't like them, of pre-completed templates. So do make sure that when you report on an X-ray, you're reporting on that X-ray, and you're not just writing the same thing in every single record. So the clinical evaluation that you record should be accurate and should be appropriate to that patient and that radiograph. So in short, your records should show what should happen as a result of taking the X-ray. So you've taken an X-ray, you've reported on it, and then you then should record what should happen as a result of having taken the X-ray and evaluated it. Now that could be no treatment required. That could be reporting on whatever pathology you see and the treatment that is required. So a complete record there is really important. So good clinical records should show why the radiograph was needed, who justified and authorized it, who evaluated it, what was found, the image quality rating, talk about that next, and then what any follow-up or action is needed, having taken the X-ray. We'll talk a little bit now about image quality rating. So this used to be recorded as 1, 2, 3, and the current guidance really supports changing the way you report, although I did have a discussion with a dentist recently who said didn't think that A and N, so A meaning acceptable diagnostically and N meaning not acceptable diagnostically, was helpful enough to him in his practice. So he was going to continue using 1, 2, 3, and felt that he could easily justify that. But current guidance has moved away from 1, 2, 3. The reason being that too many X-rays were reported as being 1 when they probably were more like a 3. And so this makes it, this is very, very clear now. Is the X-ray acceptable diagnostically? So can you see what you wanted to on the X-ray, so that you justified the X-ray, you've said what you're looking for and why you're taking an X-ray? Can you actually see that on the X-ray? In which case, is it acceptable diagnostically, or can you not see it on the X-ray? So if we go back to the bite wings taken instead of a periapical, you would have to judge that bite wing as not acceptable diagnostically because it has missed off the apex of the tooth because you took the wrong view, the wrong image. So image quality should be monitored and recorded, and ideally every radiograph you take should be graded as A, acceptable diagnostically, or N, not acceptable diagnostically. And if you've got any N recordings, then these should be reviewed as part of your QA process with the aim of making sure that there are no more unacceptable images taken. Now, that we'll come on and talk about in more detail in a moment. So now we're going to talk about QA, quality assurance. We're going to talk about diagnostic reference levels, and we're going to talk about audit. So what should your quality assurance cover? Well, it should cover your written procedures, and it should make sure that your written procedures are, and I know I keep repeating this, are up to date, current, and reflect the 2024 changes. Plus also, you should make sure that they reflect what actually happens in your practice. So it should cover making sure that your training and entitlement records are up to date and complement each other. It should cover your equipment. It should cover processing and review of your image display. And it should cover your image quality review being A or N. It should cover repeat exposures. So it should look at why you've got repeat exposures. Is it poor technique? Is it if you're using film? Is it because your processing techniques the chemicals are expired? There are, I know, still people who don't use digital X-rays, although far fewer than they used to be. So if you are having repeat exposures, why? And your QA process should throw that up and prompt an action. So when a problem like that is identified, then it should then prompt a review and remedial action. So with quality assurance, what you're aiming for is a live system of reviewing and then responding. So QA just on its own. So if you just do an audit and you come up with, oh yes, we've got we've got 30% repeat exposures here, and you do nothing about it, then that's your quality assurance not working. So it is very much about a live system where you review what you're doing and then you decide if there is a response or remedial action required. Otherwise, it's just a waste of everybody's time. So what does poor documentation look like? Well, that would be that that in the records it just says X-ray taken or bite wings done, and you've got no context, and so you have no idea why the X-ray was taken, or indeed what X-ray was taken, or why the bite wings were taken. So you must make sure that that is justified in the records. And so there is no clear clinical indication for why you've taken this X-ray, no traceable authorization. So I mentioned just now that it should be clear who authorized the exposure, or no clinical evaluation, or it's just vague. So it just says something like 2 bite wings taken, NAD. That, or as in no abnormality diagnosed, that is too vague, and so it just needs to say what you see on the X-ray. So no pathology noted would be fine, or there's unclear referral detail. So that is where your documentation shows that you have referred a patient somewhere else for an X-ray, but you have not been clear about why the X-ray is required. We're going to talk now a little bit about the employer's written procedures. So written procedures translate the regulations into what you do in the practice. I've mentioned already they should use current terminology, be practice specific and clear, and they should be usable by staff, and they should be reviewed regularly. They should also match what actually happens in your practice. Now that's repeating a lot of what I've said already. What should they cover? They should cover your entitlement records and training. Talked about that already. They should cover referrals, patient identification, justification, authorization. They should cover clinical evaluation, and then they should cover diagnostic reference levels, incidents, quality assurance, and audit. So they're comprehensive documents. What do weak written employers' procedures look like? So outdated terminology or pre-amendment wording. So I mentioned that using the wrong terminology, terminology that says IRMER 2017, that would be a giveaway that it is your procedures are probably out of date. So make sure that that is up to date. Copied text with no local details. So this is sort of generic information that you have not tailored to your practice. Vague responsibilities, or some of the procedures are missing. It's not what actually happens in your practice, and you've got no evidence that the procedures have been reviewed. So in effect, they're just something you've downloaded from somewhere and haven't made your own. So we're going to talk a little bit now about diagnostic reference levels. So these are reference values that are applicable to standard examinations. So how much radiation is delivered by taking a bite wing or 2 bite wings or a periapical or an OPG. And these should be established with your medical physics expert. And you should then have a procedure whereby you compare the established reference values for standard examinations and procedures in your practice with what is actually happening. So that allows you to identify any unexpectedly high doses. So these should be part of your audit procedures. Are we within our limits for X-rays we actually take compared to the values that were set by the medical physics expert? And if you discover that your doses are high or higher than those set with the medical physics expert, then that should prompt remedial action. And there could be a number of reasons for that. So the setting is not appropriate. So it's the dose is set too high on the machine, or the machine needs servicing or maintaining. There'll be any number of reasons. But what is not okay is if you find that the doses that are actually being delivered are higher than the standard values for your practice, then that should prompt remedial action. So audits now. So basically audit should tell you whether the systems that you've put in place in your practice are working or not. Now I've mentioned a few times that they should be living documents that you do an audit and then you review it and you look at what was found, and then you decide what, if any, action is required, and then you take the action, and then you should follow up to check that remedial action has been effective. And if you don't close that audit loop, then again, it's a waste of time. So I'm a very passionate believer in this. Audit should never be a pointless tick box exercise. It's, as I say, it's a waste of everybody's time, and it actually doesn't move you forward. So don't do audit just because you think somebody might check that whether you had done an audit or not. Audit should deliver you with a view that is either that everything is working beautifully or that some things need to change. And if things need to change, then change they should. And this should also support learning and continuous improvement. So audit should deliver improvement. If everything is absolutely as it should be in the audit, and that's an honest assessment of everything that's happening, happy days. If things need to change, then this is your opportunity to change and make improvements. The 2024 amendment reinforces the importance of audit. Now, I see quite often when I go to practices or do reviews, I do often see audit really just being done as a tick box exercise, and it is completely pointless, whether that's an infection control audit or a patient record audit, or indeed a radiation protection audit. You know, don't make it a pointless tick box exercise. Make sure that the audit is honest and actually records what you found, and that you allow it to help you improve things in practice. Okay, so now we're going to finish up now talking about incidents and learning from incidents. So when things go wrong, and they do, and now, as I said earlier, it doesn't necessarily have to mean that your X-ray machine has suddenly started dosing the patients, that the patient dose is far too high, that there are many reasons why things don't go as they should do. And so that you are accidentally or unintended, or you have accidental or unintended exposures. And so this should be recognized promptly. And when it's been recognized, this should lead to learning and corrective action. So not just, oh dear, something's gone wrong, but it's something's gone wrong, and what can we do to make sure that A, that it doesn't happen again, and B, that we learn from this mistake. So let's say you've got an unintended or accidental exposure, and as I say, there could be many, many reasons for that. So it could be you've taken an X-ray of the wrong tooth. It could be you've taken the wrong view, the wrong image. That there will be many different reasons for it, but ensure that the patient record is complete and factually accurate, because the patient is the one that you have irradiated. So their record must reflect accurately what happened. Involve the right people promptly, so that is likely to be the clinician, it's likely to be the employer. If you have a radiation protection lead, radiation protection supervisor, then that person as well. And it could be anyone to whom authority has been delegated in the practice. So it's the right people in that situation when you recognize that something hasn't gone quite as it should do. If the accidental or unintended exposure is due to faulty equipment, then that equipment, because it's malfunctioned, then that equipment must be withdrawn immediately, and it must be labeled as being unsuitable for use, and you must, in fact, if necessary, take the plug off it or do whatever you need to do to make sure that that machine is not used accidentally. And then have a think about whether a dose assessment is required or expert input is needed. So that will be from your medical physics expert, or it could be from the radiation protection advisor if it is equipment malfunction. That's what you do immediately, and then make sure that the records of the event show what happened and who was involved. If you know what the exposure details are, so let's say the X-ray, the machine has taken, the dials have been moved for some reason on the machine, and you've taken, you've used too high a dose, then you would need to record that. That should be in the patient record. You then obviously need to have investigated it. You must record your findings, what actions you took immediately, and then what learnings you've taken from it, and what preventive measures you put in place to make sure it doesn't happen again. Then when you've got your learnings from the incident, you should, as you should do with all learnings, where you're looking for continuous improvement, share those learnings with the team. What you're aiming to do actually with all adverse incidents, and in particular here with radiation adverse incidents, the aim is to reduce the risk of a recurrence. Now, sometimes your investigation will demonstrate that additional training is needed. And so one of the actions from that is to make sure that the additional training is put in place. So we're coming to the end now, where we're just going to look at what good governance looks like. So good governance means that your written procedures have clear roles and sound entitlement, that you've got defensible justification and authorization, so that's from a patient record audit, that all images have been clinically evaluated and that's been recorded. So that all comes from that those two both come from a patient record audit, that your current written procedures are up to date and you have active quality assurance, your audit, diagnostic reference level review and incident learning all lead to improvement. That's what good governance looks like. Now, you will know, I'm sure, that the area, one of the main areas that practices stumble with at their CQC inspection is demonstrating that you are well led. So if you have, from a radiation protection point of view, if you have all of these good governance points in place and working actively and not just generically, then you are a long way down the line of showing that you have good radiographic governance. So what can you do tomorrow morning? What to look out for? So top red flags to look at tomorrow morning, or indeed this afternoon. So start thinking about whether your justification is either weak or absent. So that would be a patient record audit, and the same for clinical evaluation. Red flags include radiographs still being taken when they're due, or your assessment of when they're due rather than when they're clinically justified. So that is taking the bite wings every 2 years. Might be that bite wings every 2 years are justified for this particular patient, but you should use the selection criteria to decide whether they are due or not. Clinical records that have just say periapical taken or bite wings done with no clinical evaluation. Poor image quality with no analysis or action. So those are things you can look out for right away. And here are some more. Look at your written procedures. Make sure that you are clear about who your duty holders are. So they should be named. Your duty holders should have entitlement records and they should have appropriate training records. So look to see whether that is clear in your written procedures. Look to see whether any of the training records are missing or if everything is there. Check to make sure that your written procedures are not generic, or make sure they're being used. Red flags also missing diagnostic reference level review, or just token QA, which is, as I say, where you just pay lip service to it. Poor incident handling and little evidence of learning. So those are the things, some of the things you can look out for tomorrow or even this afternoon. And so just coming to a close now, key takeaways to take away from this session. IRMER is complicated, nobody likes it. Hopefully, though I've simplified it a little bit for you, bear in mind that IRMER protects the patients, IRR17 protects staff and the public. Every exposure must be justified, authorized, optimized, and evaluated. Records should make clinical decisions and findings clear. Written procedures must be current, specific, and usable. And safe radiographic practice is not only about doing the right thing, it is about being able to show that you do the right thing. So having evidence, which I have stressed throughout this. And then for anyone after all of that who says, oh, why bother? There are lots of reasons actually, and it is a legal requirement. This is nothing to do with the CQC now. This is the ionizing radiation regulations, so that is IRMER and IRR17. It is a legal requirement to follow them. GDC requires it, and just to let you know, the CQC does have an IRMER team. So if the CQC doesn't like your radiation protection procedures, then they have a IRMER team that they can send into the practice to go through everything with a fine-tooth comb. So from a protective means, then that's another reason for bothering. But actually, I'm a great believer in doing the right thing because it's the right thing to do. And it's morally and ethically the right thing to do to make sure that you are protecting your patients, your team members, and the public from radiation that are from ionizing radiation. And it is not acceptable to be accidentally irradiating people or not protecting them in all the ways that we've discussed today. And that to me is the most important reason of all. Now, as I say, I know people love to hate IRMER, love to hate radiation protection. It's taken me hundreds of hours to put this together to try and make it understandable for you. If you feel you would like some help, then Dentistry Compliance will be very, very happy to help you. You will get a PDF of this presentation, and I will include contact details on that. I haven't included contact details here, though. So I hope that's helpful to you. I hope everyone's still awake. I haven't put you to sleep for the afternoon session, and I'll just have a little look now and see whether there are any questions for me to answer. Right. Okay. So if you haven't already put a question in here, if there's anything you'd like to ask me, do please pop it in here and I will do my best to answer it. I can't see any questions in there. Can you, Rose?
No, not currently.
Okay. Well, we'll wait a few minutes and see whether any questions pop up. So please feel free to ask me anything. Rose will send you certificates and slides when you've evaluated the session. And if you need any help, as I say, please do get in touch. So anything anybody wants to ask, and actually, do you know what? You can use this, GDC registrants, you can use this as 1 hour towards your 5 hours of IRMER training in a year, in 5 years.
Pat, is it worth mentioning about the last session in the series as well, that I could pop the registration link down in the chat for Wednesday the 8th of July is the last webinar in the session, and I believe you're going to do like a summary of the key insights and like a final overview of the webinars in this CQC series for us, Pat, aren't you?
Yes, that's exactly what I'm going to do, Rose. Thank you very much. And I promise you I won't bore you half to death with more IRMER stuff. I'll just mention it briefly because we've only just done that. But yes, I will summarize everything that we have looked at over the last 5 sessions, so that the session 6 will be a summary and key insights and final overview. Thank you very much to the person who said they have no questions and it was completely clear. Wonderful. Thank you very much. Makes it all makes it all worthwhile. Anything else at all? If you think of anything afterwards, don't hesitate. Just let Rose know and she'll pass it on to me. and I'll do whatever I can to help you. Rose, I think the silence means
yeah.
Either everyone's asleep, which is entirely possible, or they gave up halfway through and went to finish their lunch, which is also entirely possible, or there aren't any questions. So thank you all very, very much indeed for bearing with me through that. It is complicated, and hopefully I managed to simplify it for you. So I look forward to the last session then in July, and wish you all a good afternoon and a few weeks till we meet again.
Thank you, Pat.